couple of things come to mind. First of all, it's very important. This is almost lost in the noise. I don't want this to get lost. It's not IV.
It's not IV. It's a subcutaneous route, and so
How many cc's?
typically you can infuse about 1 to 2 milliliters at a time. And so obviously as you get older, you might have to do 2 injections, or if you're doing once a month injection, yeah, if you're higher weight, you might have to do it since it's a weight-based dose.
2 injections once a month as opposed to a bunch of cc's every couple of days?
Yeah, and the volume for an inhibitor patient, like if APCC volume could be 100, 120 milliliters, and you're talking about comparing to 5-6 milliliters, it's just dramatic.
That's big. And again, it's once a month.
Yeah.
Does it maintain effectiveness continuously across that month, or does the effectiveness begin to decrease as you reach the end?
So there's a specific loading regimen in which you have to load a specific way at a specific dose of 3 milligrams per kilo weekly. And once you reach that steady state, there are very few peaks and troughs because the half-life is 28 days. And so they didn't compare them directly, the weekly, every 2 weeks and every 4 weeks, but it provides that option that, and the great thing is you're not dosing more. So if you give somebody once a month, you're giving them the same monthly amount as somebody once a week, which is, I think, is a good option for the pharmacist as well. So we're not encouraging people to do more product. They just get a choice in what works best for them. And so we don't know if once a week is better protection than every 2 weeks, but maybe for the active children, once a week might be better. Sometimes you worry about people forgetting to do it. If you do it once a month and you miss a week or two, you might start to drift down.
I was going to ask about.
Yeah, that is the challenge. Is we have a lot of patients who are not adherent to their regular kind of standard half-life or extended half-life prophy regimen, and most likely, if they're not adherent to that, they won't be adherent with this.
But let's not blame the patients completely. I mean, there's the famous study, right, in which they gave medical students, highly motivated.
Yes.
One would think intelligent, with present company accepted, and they gave them placebos. All they asked them to do was take 1 pill a day for a year. And then they looked at the number left over, and it was about 30%. Yeah. This is not bad people.
This is a human problem.
This is a human problem, right?
Yeah. I forget to take my Zantac every day, I can tell you. So I just forget to take it, and I notice it later, and then I take it again, so yeah.
But I think some of those challenging patients that, if we have the option to go once a week, every other week, or once a month, we can have them come into clinic and then give them their shot. At least we know that they're adherent.
And we hope that you guys are going to help provide reminders. We always tell people to have phones, set reminders, but not everybody does that. And so we're still going to rely on the pharmacist to keep track, and these medical bleeding logs are going to be important.
Why do I come back to you? There's an app for that.
Yes.
Once a month, bing, your phone goes off.
Yes.
That should work.
Yeah, and like he mentioned before, one of the apps does have a way to connect to your pharmacist, connect to your center, and so I can track it, so I can see he forgot to give his dose last week, and then one of us will give a call.
Now, there's a black box warning. We can't go past this without discussion.
Sure.
On emicizumab. What is this black box? It sounds scary.
Sure.
Is it scary? Should it be scary?
Well, I mean, it's just, and it comes down, so I was involved in the clinical trials, and so what happened was in the first trial, the Haven 1 study, when patients bled, you still have to use those bypassing agents that we talked about, APCCs or recombinant factor 7. What we learned is that now that you're on emicizumab, you don't need to use as high doses. And unfortunately, the first bleeding event, somebody used very high dose of APCCs, and they developed a sinus thrombosis. And so, and then there were a few other events that developed, they developed something called thrombotic microangiopathy, and it was
sounds scary.
Thrombocytopenia, acute renal injury, and microangiopathic hemolytic anemia. And what we learned was the unifying characteristic is that they were getting over 100 units per kilo of, in a 24-hour period of that APCC. And so a dear investigator letter came out. We were all warned to look for this, not to do this. And since that, we have not seen any of those events because we've shifted to use to recombinant factor 7.
It's interesting to me that the problem was not insufficient clotting.
No, it was
but
excessive.
over-aggressive clotting here. You can take that because you can pull back on that.
Yeah, so it's different, and as you know too, is that we tell these patients, if we have a kid that trips and hits their head, we're throwing the kitchen sink at them because we know they could be treating that bleed for a month afterwards. And so we often say aggressive, don't, give factor first, ask questions later. It's the same thing when they show up in the emergency room. We tell the ED doc, if the mom says he hit his head, give the factor and then scan his head. And so our mentality has changed that we need to, if that guy fell and hit his head, we probably should observe him, look at it, decide whether we want to give it.
If he's on emicizumab.
If he's on emicizumab. And so it's a slightly different mentality that we all have to get used to.